Hello everyone. Today's video is about strategies that can be used in early stages of rheumatoid arthritis to help try to mitigate the disease process or maybe prevent it from evolving. As per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please ask your healthcare provider to get that advice. And if at some point you wouldn't mind please taking a quick moment to like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. So specifically the question here was, what's the best way to eat for someone who shows early RA symptoms but doesn't want to succumb to it? I hear anti-inflammatory, but I've heard that paleo with all the pasture hoof type meats is even better. So thank you for the question. Yeah, so I mean, this topic, I know the question is about early RA symptoms, but I feel like quite frankly, my answer would be the same, if there was early ankylosing spondylitis, early psoriatic arthritis, even, early MS, like really any early stage autoimmune condition, I think the answer would apply more broadly. So this is really for autoimmune issues in general, I suppose. Diet-wise, it's something where there isn't a one-size-fits-all diet for everyone, and that would include folks that are dealing with some type of an autoimmune condition, early stage or otherwise. In some cases, a patient might need to go like really strict. They might need to work with something like a full-blown carnivore diet. In other cases, we might take a step, in the less strict direction and work with a low lectin diet slash autoimmune paleo diet. In other cases, we might be able to get away with using like a modified ketogenic diet, or maybe like semi-strict paleo diet. In some cases, just a paleo diet would be okay. In some cases, just going gluten-free, maybe dairy-free, sugar-free, or minimizing those foods would be adequate. So the way that I approach it with my patients is I'll see kind of where they're at in terms of where they're at with what they could take on in their life, how busy they are, how much Kool-Aid they've already drank in terms of, maybe they're already, on a paleo diet and it's not quite doing the trick. So, we'll talk about maybe taking things further. But if they're still, eating like just a very standard, North American diet, then we might just start with like more of a gluten-free, dairy-free, sugar-free, or minimize those foods, because that's a much easier pill to swallow, so to speak, than getting into a, full-blown autoimmune paleo diet right out of the gate. So, depending on where the patient is at, and also depending too, like on what their body composition is like, what their body type is like. I've had patients come in to see me and, they've been working with another clinician, and obviously coming from a very well-intentioned place, but they're put on a really strict diet and they're feeling really tired. They've lost a bunch of weight. They're underweight now. Like it's again, it's just not because with some of these stricter diets, especially when you start getting into carnivore or autoimmune paleo, it can be very easy to lose weight. For many people, that's not a bad thing, because a lot of people, majority of people, at least in North American society, are overweight. So losing some weight, not a bad thing. But for folks that are already at a healthy body weight or might be tending to be a bit underweight, that is not a good thing. So we need to really meet the patient where they're at and tailor it to where the patient is at. So with respect to deciding like what type of diet to work with, we'll usually start somewhere on that spectrum, and then work with a given diet for, say, maybe 4 to 8 weeks, and then see how the patient's doing. And if they find that their, say, early stage RA symptoms are doing markedly better with, say, just in quotes, gluten-free, dairy-free, sugar-free diet, then why would we go beyond that? Maybe we don't need to. Now, so we kind of look at symptom mitigation as kind of the first barometer. Let's say patient goes on a autoimmune paleo, like let's say they've tried a paleo diet, it was helpful but not quite knocking it out of the park. They go to an autoimmune paleo diet and it's just the cat's meow. Their early stage RA symptoms, their early age psoriatic arthritis symptoms, their early stage MS symptoms, they're just feeling really good. So then at that point, say, well, it looks like we've figured out the right diet to work with. Maybe over time, the patient doesn't need to be quite as strict with that diet, kind of play by ear over time as, gut healing occurs, or, the immune system just kind of settles down more. Maybe they don't need to be quite as strict. But at a certain point, we may want to also look at, and likely would want to look at, the levels of some of those autoimmune antibodies, maybe looking to see like where's their rheumatoid factor sitting, or potentially doing some blood tests to look at different, like, anti-myelin antibodies if the patient was dealing with a MS diagnosis, or maybe looking at other inflammatory markers, like more general inflammatory markers, like their C-reactive protein or ESR or whatnot, to kind of get more objective measurement, because it's great when the patient's feeling good. That's, in my opinion, the most important litmus test for are we on the right track. But we also want to ideally see that they're looking good on paper as well, that there isn't some disease, that the disease process isn't still working to erode their joints, erode their nervous system, erode their skin, whatever, in the background. And so ideally we get them clinically feeling really well, but then also want to make sure as best we can, to our best of our ability, that their lab markers are looking better too. First step is symptom improvement, then hopefully we see objective laboratory improvement as well. And so it might be that they're feeling really good on a standard paleo diet, but their labs still aren't looking great. So maybe we want to push things a little bit further with their diet to make it potentially stricter, to take a look at how their objective metrics are looking in that respect. There could, in this type of case, be a role for food sensitivity testing potentially. So if a patient was, say, already on a diet that was about as strict as they were willing to go or able to manage, and they were still having symptoms, we might want to do an IgG food sensitivity test to see if there's still indications of immune system cross-reactivity happening there. And so we might further modify the diet in that case. Sometimes having a piece of paper telling the person that, like, oh, you haven't stopped eating corn, but you seem to be really immunologically reacting to corn, that is sometimes the motivation that they need to say, well, maybe I really should cut corn out of my diet, for example. Now, those tests aren't perfect, and there's not necessarily a direct clinical correlation to, IgG reactivity is happening, and cutting out that food is going to lead to symptom improvement, not necessarily, but it would be something on the to consider list. And then over and above that, and I won't get into it in this video, I'm happy to post a follow-up video if there's interest in this topic, but it's really would be the very rare case where I would say, like, oh, let's just work with diet alone when there's early stage autoimmunity, and let's not work with anything else. No, indeed, we'd be talking about lots of other options, different immunomodulators, so things like intravenous ozone therapy, things like herbs like Chinese skullcap and Japanese knotweed, immunomodulating nutraceuticals like quercetin and NAC, possibly working with some low-dose immunotherapy that was specific to the autoimmune condition in general. So like with, say, early-stage rheumatoid arthritis, we'd be thinking about using Proteus, the Proteus mirabilis, low-dose immunotherapy formula. So we'd be looking at that. And then depending on what other types of comorbidities might be going on, if, say, the patient had symptoms or a history suggesting there was a mold toxin component, well, mold toxins can be potentially very important to address when there's a history of autoimmunity, or if there are lots of gut issues, we'd be looking for SIBO and yeast overgrowth and maybe parasites and different things like that. So we want to make sure that we were addressing kind of the comorbid things that were going on to make sure that we're taking a really comprehensive approach. To be perfectly frank, in my early days of practice, I've been practicing for a little over 16 years now. In my early days of practice, I had plenty of patients with an autoimmune, with different autoimmune diagnoses, and they did really, really, really well with, and many of them did really well with, diet, maybe some fish oil, some probiotics. Like, I saw some really, really great results. I find that over time, there just seems, in my experience, there just seems to be so much more, again, these comorbid factors like, mold exposure, patients being exposed to different viruses. I think that spike proteins from COVID, play a role in some of the more challenging cases, more persistent cases that we're seeing. There's, of course, been some links. I don't know to what extent they've been research validated, but there definitely seem to be some clinical correlations between, the advent of spike proteins in our lives and there being seeming to be a surge in different autoimmune conditions, younger age of onset and whatnot. So it's a different playing field now than it was 16 years ago. Unfortunately, not for the better in certain ways, but there are still good tools that we can work with to help try to mitigate these issues and deal with them as they come up. So I'll leave it there for now. If there's any follow-up questions on this topic, I will happily address them as time permits, or when time permits. And I hope this was of interest, and I'll leave it there for now.